we may be able to go ahead and get this chapter finished, which is nice because I'd like to get into the discussion on the heart, which is what you guys are dissecting in lab this week. And so almost everybody is done with their heart dissection. There's just, I think, 2 labs left. And 4 cuts, and then you start working on the coronary circulation after that. And then, of course, proper identification of the various structures. So don't forget to pay attention to the forum, because there will be a post pretty soon about how to make your approach towards that heart eval for yourself. Because there's a very logical way to do it, and it's always best to start with the logical way, because that's how your instructors think. And so give them back what they would like from you, and we'll optimize your score. We talked about plasma, 55% of the whole blood volume, and bulk of that is water. And then 7 to 8% of that's going to be our plasma proteins. Albumin's the main plasma protein, but there are other plasma proteins that we're going to talk about when we talk about clotting. So even though albumin is the bulk of our plasma proteins, realize there's other proteins floating around the bloodstream that are going to be utilized for other purposes. Clotting is one, and then also when we get into the immune system, complement is the other. We're going to now look at the formed elements. That's red blood cells, white blood cells, and platelets. And so first off, we're starting off with the red blood cells, and the technical term for them is erythrocytes. Erythro is red in Latin and cytes for the cell. And when you take a look at the red blood cell under the microscope, it looks quite a bit different from this cartoon rendition here from the superior view, because it typically isn't redder in the center. It's typically paler in the center, correct? So this little bit of this redness here is, to me, is a little incorrect in that aspect. But when you take a look down on it, it is definitely circular. And then they did a sectional view over here, and so it's the opposite of our lens of the eye, correct? Because our lens of the eye, how do we describe that? Biconvex, and this one is biconcave. And so what's important here is we're using those descriptors again in our method to actually describe what something looks like to us, and this time it's a red blood cell. One of the things to realize, the reason we have that now flattened area or depression, you may want to call it that, in the middle of a red blood cell, is that's where its nucleus used to live. And so red blood cells are anucleated, but everything is born with a nucleus. And so red blood cells were born or underwent mitosis from their precursor cell to the formation of the ultimately what will be the red blood cell, had a nucleus in it, and before it leaves the bone marrow, the nucleus is extruded so that we can actually increase the surface area to volume, and therefore increase transmission of the gases that actually have to go through that cell membrane to get to the inside molecule that's important in the transport of oxygen for us. So our descriptor here is biconcave disc. It has no nucleus or anucleated. It is a bag of hemoglobin. And hemoglobin is abbreviated HB, as we see down here. And it is about 45, almost 50% of our whole blood volume. Did I say 50%? I didn't say 50%, did I? Sorry, 44 to 45%. I heard myself and I go, that's not what I meant to say. All I can tell you, folks, it gets worse as you get older. You start thinking that you're saying something that's not what you meant to say. So please be patient with me and catch me before I trip and fall on my face. Our picture off to the right is showing you that we find red blood cells everywhere because we need blood everywhere. However, remember, red blood cells, or our blood, is confined in a closed system. And so what we see here is a bunch of red blood cells that when they stack up, it's got a technical term called rouleau. That's not actually anything that you'll be tested over, but that's what that looks like. They just stack up because of their very nature. And as they go through capillaries, the capillary only needs to be a little bit wider than the width of a red blood cell. And one of the things that's not a bad idea to keep in your mind and memorize is that a red blood cell's size is about 8 micrometers. Our notes here say 7.5. I kind of like to round things to a more memorizable number. So about 8 micrometers, and MCM is the better way to write micrometers instead of the mu-m. And so if you have something that you're trying to estimate the size of, you can always find a red blood cell pretty close on your microscope field and kind of figure out, is it twice the size of a red blood cell, half the size of a red blood cell, and you actually have already a little measuring stick in your slide. We see these red blood cells off to this right-hand side here are actually all in a capillary. And we know this is a capillary because capillaries are what is utilized to actually help with the diffusion of the gases to and fro our blood to the tissues surrounding it. And can you guys see that the layer around it is those flat cells, simple squamous epithelium. And it's called endothelium whenever it's inside a blood vessel, whether it's an artery, whether it's a capillary, or whether it's a vein. That innermost lining that then defines the area of the lumen or the opening is endothelium. And so I know right off the bat that we are in a capillary because it's only a simple squamous epithelial cell lining this area, and it's actually not very wide, and this is very high in magnification. They're called a bag of hemoglobin because that's what they do. They carry hemoglobin, and that's what actually gives them their lovely red coloration. And so let's take a look at hemoglobin itself because that is the molecule that is actually responsible for carrying oxygen. So remember, major function is to carry or transport oxygen. We have approximately 250 million hemoglobin molecules per RBC. Each hemoglobin carries a maximum of 4 oxygen molecules. So that means that we have greater than 1 billion oxygen molecules per RBC. So a lot of oxygen is being carried by just one red blood cell. The other thing is hemoglobin can also transport CO2. However, the binding site for carbon dioxide on the hemoglobin molecule is completely different than the binding site for the oxygens that bind to the hemoglobin molecule. Let's take a look at our cartoon picture here of what a heme looks like. So this is the heme, and there are 4 hemes per hemoglobin molecule. So 4 of them per hemoglobin molecule, and they all have iron right there in the center of that. Then we have the globin, which is a protein. You guys remember we had fibrous proteins and globular proteins. Fibrous were structure, globular was for function, and that's what we have here, a globular protein or a globin. And let me ask you, the picture of that globin there, is that a primary, secondary, tertiary, or quaternary structure? Quaternary. Because we know quaternary depends upon all the previous ones too. And so that's why we actually have, in addition to those 4 hemes, we have 4 different polypeptide chains. And it's not important that you know about alpha chains and beta chains, but that the globin molecule is a really big molecule and that we have those 4 hemes in each of those individual portions of that globin molecule. And that's where oxygen's going to bind. Oxygen's going to bind to that heme there, where carbon dioxide will not bind to that site. Let's talk about what is the stimulus for making red blood cells, these little bags of hemoglobin. The term for the need to make red blood cells is called erythro, which is red site, poiesis. So the red blood cells, the erythrocytes, have this process called erythropoiesis. This always occurs in the red marrow of our bones. And let me ask you, young adults, young and old, where is the red marrow of our bones now? Flat bones. So the flat bones of our skull, our sternum, even our ribs, and also the flat aspects of our pelvis. Okay, so the ilium, and is that it? Head of the humerus and head of the femur. So that's where our red marrow is now. When we were first born, red marrow was everywhere, and so there was a lot of hematopoietic centers, but no longer the case for us. So that's where we actually make red blood cells and white blood cells, because red marrow is also going to make red, white, and platelets. The control for the formation of red blood cells is actually hormonal. So we did not talk about this system for endocrine, but it is interesting that this is a hormonal system, which means the stimulus is put into your bloodstream and then gets to your marrow and tells your marrow to make more red blood cells. The hormone is called erythropoietin and is abbreviated EPO. And it comes from your kidneys. Your kidneys are very important organs. They do more than just create waste material for you, so get rid of waste material. They are also plugged into the bloodstream and know a lot about what's going on with your circulation. So they are monitors of your oxygen needs. Your kidneys monitor your oxygen needs. And so if you do not have enough red blood cells, what does that happen to, how's that going to impact your oxygen needs? Your needs are higher than what you have, and so you will have, the kidneys will release EPO, or erythropoietin. Decrease oxygen availability. So you decide to become a Sherpa. You don't pass A&P and you go off to become a Sherpa. Okay, so you're at very high altitude. And if you ever do that, I want to hear from you. You go off to a very high altitude. Why are you going to actually have your kidneys going to release EPO? Why are they going to do that? Because the higher you go, the less density for the gases, right? Which means you have less oxygen available to you. And so if you have less oxygen available to you, you need to, what I call, upregulate. Do you guys remember about that hormones where we upregulate? We have less, so we need more to grab whatever's in the environment. And so that's what's interesting about people that live at high altitudes. Their blood is literally thicker than ours at lower altitudes or at sea level. So the higher up you go, the less oxygen in your environment. So therefore, you will actually produce more red blood cells because the kidneys will release EPO for that. And then increased tissue demand for oxygen. So what are some situations that are good examples of increased tissue demand for oxygen? Regular exercise? No. What kind of exercise might cause? Strenuous? Once a day? Once a month? Once a week? How about those marathoners? What do you think? Marathoners, they exercise for a long period of time, and they are needing to make a lot of ATP, obviously, to fuel the muscle machinery of their bodies, and oxygen is very important for making a lot of ATP. So marathoners will have thicker blood than non-marathoners. And then what about what we just talked about at the end of the last semester? What about the general adaptation syndrome? Are you in metabolic overdrive when that hits? And so those things which actually can initiate the general adaptation syndrome also will tell the kidneys to release erythropoietin, because we need more red blood cells to carry oxygen to all these revved up tissues that are trying to save us. So those are just some basic examples of that. Now, the interesting thing also about EPO is artificially made. So the kidneys were the source of erythropoietin originally, and then we found out we could make it in a lab. And so we started making it in a lab, and that became problematic. And why did that become problematic, so to speak? There's people that will do anything to win, right? And, you know, they get addicted to that feeling of winning and all the high that's brought to them. So marathoners will do this. Lance Armstrong did this. And also people who participate in Russia Olympics do this. Why would they want to do this? Why would they inject themselves with erythropoietin? More oxygen, better endurance, better performance. Absolutely, because more red blood cells, more oxygen carrying capacity, and more metals. So this is part of the doping scandals that you actually have. And so the problem is erythropoietin is naturally made. And so they have a lot of sophisticated tests that they have to do on their athletes in order to assure that no doping is actually occurring. The other thing that's an interesting way that you can cheat, because there's always ways to cheat. You know, human beings are always creative on figuring out another way around a formal process. But it's called autologous or autotransfusion. And so all you have to do is donate some blood that you put back in yourself. When you donate blood, what are the kidneys going to do? Going to release erythropoietin because you lost some blood. And so then you'll get tanked back up, and then you'll put your own blood back in you, and it's really difficult to actually be able to ascertain that you've got more in your tank than you should have under ordinary circumstances. So there's a lot of difficulty that these various committees actually have on trying to make sure people are true performers and not cheating on how they actually are able to perform to the optimum. So I'm pretty sure Lance Armstrong probably knew about both methods and probably employed them both. Never heard what the formal thing was about what he was using, but you know, if you know a little bit, you can actually figure it out. Yes?
Would there be a way to differentiate between natural erythropoietin and blood?
It's just like insulin. And they made it in the lab off of the human form. So that's why we have a lot of difficulty with that. Let's take a look at, good question, wish there was, but there isn't. They'd have to tag on to the erythropoietin molecule some additional things that would not hopefully cause your system to destroy it right away, because we do give erythropoietin to people for real reasons. And one of them is cancer treatment. And also people who are undergoing renal dialysis. Their kidneys aren't working, right? And so therefore the signal to make red blood cells is actually not being put out. So erythropoietin was designed, the treatment was designed for situations where we were having inadequate kidney function and also chemotherapy. Dietary requirements to make a red blood cell are the usual, which is, you know, it's going to have phospholipid bilayer and cholesterol and proteins and all that kind of stuff is what we're talking about. That carbohydrates, the usual diet stuff. Plus, you must have, in addition to that, you must have iron, you must have folate, and you must have vitamin B12. And this is important because, as our notes say, it's necessary for the DNA synthesis of the red blood precursor cell. So remember, there is a cell with a nucleus that is the precursor to red blood cells. It will divide, and before that red blood cell is ready to go out into your bloodstream, it will have the nucleus extruded before it actually leaves your bone marrow. So you need all of these things. So what happens if you have a deficiency in any one of these things? What's the typical name for this when you don't have enough red blood cells? Anemia. Anemia will result if there's a deficiency in any one of these things. Fe's for iron. Folate, I don't know the abbreviation for folate. Or vitamin B12. Vitamin B12, the reason they actually always call it vitamin B12, it's cyanocobalamin, is its really long name, and sometimes it gets a little bit of a tongue twister at times. So vitamin B12. So any of these things can cause deficiency. What group of people are the most common group of people that have iron deficiency anemia? Pregnant women, or not pregnant women, yes, but pregnant women will, because they're actually volume overloaded. They actually have enough red blood cells, but they have a lot more plasma than they ordinarily do. Also, women in general that are menstruating. Also, there's groups with dietary restrictions, and those are vegetarians, correct? Because where do we get most of our iron in our diet? Red meats. That's right. We get our iron from our red meats, so those proteins and stuff like that. Now, folate and B12 are both B vitamins. The interesting thing is folate's actually pretty easy to obtain in your diet if you eat a lot of fruit and vegetables as well as meats, but vitamin B12 is an interesting vitamin in that it's the reason for what is called pernicious anemia. Has anybody ever heard of pernicious anemia? It's a very specific, all of these will give a very specific type of anemia because it will affect the appearance of red blood cells. But B12 is important because you have to have a normal acid environment in your stomach in order for proper B12 absorption from your diet. And we have a lot of people that don't have a normal acid environment in their stomach. Do you guys know what I'm talking about?
People that take Tums.
People that take Tums take it because they have a lot of acid reflux, but that's not going to stop acid production. So there's actually medications out there over the counter that stop acid production. Yeah, Prevacid, Prilosec, all of those types of things all stop normal acid production and all stop the formation of that component that's necessary for normal B12 absorption from the gut in your diet. Fate and destruction of red blood cells, they have a 120-day lifespan. So after 120 days, are you dead? No, that's right. Because 10 die today, 10 die tomorrow, 10 die the next day, and each day we have 10 die, we have 10 more to replace them, correct? So we have this lovely replenishment that actually goes on. The broken cells are phagocytized in the spleen and the liver. So the spleen's a big player for the bulk of this, and then the liver is also going to play a big role in what I call the recycling component. Now, they're broken because red blood cells lack something that helps them to repair any damage that occurs to them. The nucleus. So remember, the nucleus is important in actually providing replacement parts for whenever things get damaged or used. And the red blood cells are like inner tubes floating down one of those water slide parks, day after day after day after day after day after day. And they're always hitting the walls. And the walls actually are relatively solid in comparison to what the red blood cells make up is expecting. And so as you go along, you will actually get traumatized and you literally wear out and pop just like a tire. So when they pop, what happens to the hemoglobin inside them? It's dispersed into the plasma. The components of red blood cells are, after they're phagocytized, they are basically broken down and then recycled in the liver. So the spleen's the bigger player in uptake, but the liver is the biggest player in recycling, breaking things down and recycling. The unusable part of heme, we're not able to actually break hemoglobin all the way down, and so there's this heme that we cannot recycle, and we make it into bilirubin, which is put into your bile. Your bile is stored in your gallbladder, And bile is released into your digestive tract whenever you have a high fatty meal. And so we are able to then put it in the pooper system so that it leaves the body. We can't recycle it, so we'll just dump it on out. And what's interesting is the bilirubin is what actually gives your stool its lovely color, because the bacteria in your gut use bilirubin to actually then create the brownness of your poop. So dispose of liver by the liver in bile. Now let's take a look at leukocytes, or white blood cells, WBCs. Less than 1% of our total blood volume, all white blood cells, or leuko is for white, possess a nucleus. They are also produced in the bone marrow, but in addition to the bone marrow, you will also find white blood cells in your lymphoid organs. And those white blood cells are lymphocytes. So those in your lymphoid organs are lymphocytes. White blood cells are cool because they can almost act like a bloodhound. They exhibit this thing called chemotaxis, the ability to follow the chemical scent that's being actually left behind by an offending pathogen, or even players of your immune system trying to get rid of the pathogen. Margination, white blood cells can actually line up against the capillary wall when they hit the area close by to where the offending agent is. And then these are bigger cells than red blood cells. They exhibit this component called diapedesis, where they act like some sort of ghost on Ghostbusters, where they literally can squeeze in through a crack and come out on the other side whole. And then once they're in the soft tissues, then they're having to come up with a locomotion way, a way to move around, and so they exhibit amoeboid movement. And so it is moving by itself through soft tissues or connective tissue. So let's take a look at this nice little YouTube about this process. It worked really well the other day. Let's see if it works today.
Neutrophils are by far the most abundant type of white blood cell at 60% of our overall count. These cells are usually the first to the scene of bacterial or fungal infections. This neutrophil is chasing foreign bacteria. Eventually, it catches the bacteria and is engulfed into the neutrophil cell membrane. Neutrophils are incapable of renewing their lysosomes, so after digesting just a few of these, they will die. Neutrophils, along with other cells, find their way around by a process called chemotaxis. Following a specific chemical signal, these neutrophils are guided to the site of inflammation within minutes. Leaving the bloodstream, they migrate into the endothelial cells to reach their point of destination.
So that's a capillary wall right there.
Once they have arrived, they will begin phagocytosing any bacteria present. Neutrophils suffer high casualties, and the result of this is visible in pus seen around the site of a wound.
Lots of great YouTubes out there, you know. So let's take a look at our 5 different types of WBCs that we have. There are 2 categories, granulocytes and agranulocytes. And this is all dependent upon when they first identified them under our compound light microscope. They could see granules produced by staining methods of 3 types, and they couldn't distinguish real granules in the other 2. So that's why we have the terminology granulocytes and agranulocytes, though there are actually granules in both. Neutrophils, as stated on our YouTube, is at least 50% of your WBC count. So that one said 60%, but we'll stick with 50% plus. So we're right in that category. They have indeed faint granules. They're kind of neutral in their stain uptake. And the nucleus of a neutrophil has 3 to 6 lobes, and so is multi-lobed. And it's a funky looking nucleus, and we'll take a look at that in a moment when we take a look at the pictures that I have of all 5 of these guys. So it is the one that is definitely multi-lobed. It is a phagocyte that is associated with our acute bacterial infections because it is the most numerous of our WBCs, so it's the one that obviously is going to be there in highest numbers whenever we have any bacterial infection. The granules inside them are enzymes as well as an antibiotic-like protein group called defensins. So these defensins are capable of poking holes into cell membranes of our bacteria. And when you poke a hole into the cell membrane of a bacteria, things get out, which means the insides of the bacteria get out and therefore die, and also water gets in. And that's actually one of the main things that happens. Water gets in and causes the bacteria to explode from osmotic pressure, now that we're able to do that. The other enzyme that I want you to know about is that we can actually form peroxides that are also designed to actually kill the pathogen that it has put into its vacuole that actually combines with the lysosome. So those are our neutrophils. Eosinophils are 1 to 4% of your white blood cell count, and the granules indeed are dark red. The nucleus has 2 lobes, and the granules are actually enzymes that are designed to kill parasitic worms. And so these enzymes are meant to be dumped in the extracellular environment. These cells aren't big enough to take up parasitic worms. They will actually surround the worm and then pour their enzymes out onto it and kill the worm that way. The problem is these are very caustic or inflammatory enzymes and indeed can contribute to tissue damage. And so if you have a high eosinophil count, you will have a lot of inflammation associated with that typically. There is a group of people that actually has a tendency towards a high eosinophil count, and those people typically have the condition called asthma and allergies. And I mean serious allergies, not a little bit here and there. So long-standing inflammatory conditions that we see with asthma and allergies, typically higher in those individuals. Basophils, which are the least abundant of any of our WBCs, 0.5% of the leukocytes, has very dark blue-black granules that contain the chemicals histamine and heparin. The nucleus is typically U-shaped, so it's a fairly good-sized nucleus. And histamine is a very potent vasodilator, which means increases blood vessel diameter, contributing to making the blood vessel leaky. What do you guys know about heparin?
Blood thinner.
It's a blood thinner that also allows for more material to get into the soft tissues. The more material you can get into the soft tissues, the more actually swelling you get and the more fighters for infection actually get there. So there's an actual reason for this. But these guys can actually, if the number is increased, these guys can actually cause a lot of problems like anaphylaxis. So whenever they dump their chemicals, we will have an increase in the inflammatory response in an area. Agranulocytes have absolutely no distinct granules with the light microscope. And there's 2 categories, lymphocytes and monocytes. And lymphocytes are the second most numerous of our WBCs, and they will always be 25% or a little bit more of our WBC count in a normal person. The 2 cells of lymphocytes that we're going to get into when we talk about the immunology chapter are B cells and T cells. So lymphocytes are very important in our immune system, and they have 2 main categories, B cells and T cells, or B lymphocytes and T lymphocytes. Monocytes are about 5% of our WBC count, and when they are in the soft tissues, they are called macrophages. So in the bloodstream, you can easily identify them as monocytes, but once they get in the soft tissues, you can't identify them as monocytes anymore because they are actually now macrophages and phagocytic cells. So let's take a look at our histology and cartoons here. So I always ask you, remember I asked you to take a look at the red blood cell size, and now let's see, of those 5 different cells, which of them is the smallest of those 5 different cells in that picture that we have here? The lymphocyte. And that's what's important. The lymphocyte is the smallest of our WBCs, and it is predominantly all nucleus with a sliver of cytoplasm. That's how you identify them. They are the second most numerous of our WBCs, so you will find them all over the place. Now, let's take a look at that neutrophil above that lymphocyte. Is it smaller or bigger than the lymphocyte? It's bigger, and it's about the size of 2 red blood cells, yes? And so it has that funky looking nucleus, and that's what's really important. Neutrophils truly do have a funky looking nucleus, and so they'll have nuclear material that's kind of hooked onto some more nuclear material that's got another loop to nuclear material, and so that's what their nucleus looks like. It's all interconnected, so they're able to actually share the DNA throughout that thing, but the nucleus is just really odd looking, and that's why it's called multi-lobe. The granules are apparent, but they don't take up the stain anywhere like the next guy, the eosinophil. And so you see with that eosinophil, you see all of those dark red granules. And the nucleus is kind of easy to see in those guys. And also, it's larger. Take a look at it compared to the red blood cells next to it. When we take a look at the basophil, a lot of people think it looks like a lymphocyte. And at first glance, it does. But what's the difference between a basophil and a lymphocyte? Size. Size is the #1 clue to the difference between a basophil and a lymphocyte. And remember, basophils are not numerous in your tissues, and so whenever you come up to something you can't figure out whether it's a lymphocyte or basophil, you're probably safer off calling it a lymphocyte until you're under high enough magnification where you can see the granules. And don't those granules obscure the nucleus in that thing? So it's really hard to actually even see the nucleus in a basophil. Then the largest of the cells are the monocytes. So they have this huge nucleus, they have obvious cytoplasm without granules, and they are indeed the largest size cell of our WBCs. Let's talk about platelets real quick. Platelets, abbreviated PLT. They are fragments of a very large cell called a megakaryocyte. So really big cell. And what happens with the megakaryocyte is that it actually pinches off pieces of its cytoplasm and cell membrane, and that's what platelets are. So platelets contain the same thing inside them that the megakaryocyte had in its cytoplasm, which is very important because we're going to see that platelets are important in our clotting of our blood. They also have another name called thrombocytes. Is there anything there that makes you realize that this is going to be part of a clot? Thrombo, that's right. Part of our clot formation is going to have thrombo in it, and we're going to see a lot of that with some of the enzyme in the enzyme cascade that's part of that. What I like about this scanning electron micrograph picture, it shows you a clot. It shows you the platelets here, these little paler looking collections here. It shows you fibrin threads, which are just all throughout this. And it shows you the bulk of the clot is made up of red blood cells. And what do clots look like? Bloody jello, right? Blood jello. So you have to realize that the reason that they look that way is because the blood gets trapped in this process of actually closing off the hole that was made in the blood vessel. So let's take a look at that topic, hemostasis, the stoppage of blood flow. So this means, remember, our blood vessels are closed, and this means that we actually opened up the system. We created a hole in this closed system, and we have to put our finger in the dike. We cannot have this blood leaving this system because it's bad to have blood in your soft tissues. You guys know your If you have blood in your soft tissues, it's typically, you'll call it a bruise, is the most common thing that you'll see. And it goes through all different color transformations before you can actually get it out. So it's hard to get it out of those tissues. And the toxins released when red blood cells break down in soft tissues is causing the pain that you actually also experience with the bruise. So hemostasis has 3 phases: vascular spasm, platelet plug, and that term coagulation. And your body does the same thing that you would do if you were cutting vegetables with a really super sharp knife that nobody told you they sharpened, and you ended up cutting yourself, almost feeling like you cut yourself to the bone, and you started to bleed all over the place. What would be the first thing you would do besides drop that silly knife? You'd grab it. Vascular spasm. You would try to tourniquet it, right? And isn't that what vascular spasm is all about? We're trying to tourniquet that to where it actually doesn't keep bleeding out all over the place. We want to keep it in the system. So vascular spasm is an important first step in hemostasis. And this is a neurological process. Because it indeed is quick to start and will fatigue. And so what's nice about this, it is able to reduce blood flow for up to 30 minutes. Blood flow out, not. Because that's what we're trying to do. We're trying to stop your blood flowing out of you. Okay. So that's vascular spasm. Then what would be the next thing you would do after you've grabbed your finger and trying to stop the blood flow? You get some sort of towel, rag, paper, something. You grab something to put it over. That's our platelet plug. So our body does the very same thing. And the platelet plug is designed to be a temporary platelet seal. It is going to give you more time to prevent more blood loss. And this is what's interesting about platelets. Platelets are floating around in the bloodstream and they're ready to stick to anything that will allow it. If you have a normal, I have not a normie day today. If you have a normal intact endothelium or lining of your blood vessel, those healthy cells are always releasing chemicals that prevents platelets from actually sticking to them. So they're releasing this, we'll call it a pseudo slime layer, that platelets will not actually adhere to or recognize. And so what happens is when you cut a vessel, then you obviously damage the cells. Plus you expose that stuff with which our endothelium sits on. Remember, our endothelium always is going to sit on CT. Right? So if you cut across an area, in addition to muscles and other things like that, you're going to cut through the connective tissue, which is typically the supporting structure for any of our epithelium. Okay? And so when you cut through the connective tissue, what's the major thing in connective tissue? Fibroblasts making, but they're not the major thing. Collagen. And this exposed collagen also is like an attractant for platelets. So this will cause our platelets then to actually stick to this area because we no longer have that protective chemical, and now collagen is also being exposed. And platelets are known to release 3 chemicals into their environment. They'll release serotonin and thromboxane A2 as well as ADP. All of those chemicals are going to cause more platelets to aggregate. So causes additional platelets to stick is basically the same thing as saying platelet aggregation. When a group aggregates, a whole bunch of people come on in. So we'll bring in a whole bunch of people and we will be even stickier because of ADP. The other thing serotonin and thromboxane A2 does is it enhances vascular spasm. So as our neural control starts to fatigue, guess what? We are now putting a hormonal mechanism in there to help also prolong that vascular spasm. So platelets are also helping to prevent blood loss out of our vessel that's been compromised. The next thing that actually happens now in hemostasis is coagulation. There are going to be 3 events that we're going to talk about after we go through some definitions. But remember, coagulation is going to take our liquid blood and make it into a gel, which is what our clot is. Let's take a look at these terms real quick. Procoagulants, anticoagulants, thrombus, embolus, and hemophilia. Procoagulants are the various clotting factors actually synthesized by our liver. And these are actually plasma proteins. So they're in your blood just like albumin is. So they're all part of that. So we have lots of procoagulants floating around in our bloodstream, but they're not activated. We also have floating around in our bloodstream anticoagulants, naturally occurring anticoagulants. And what's nice is the anticoagulants typically dominate the procoagulants. Which is really great. You'd rather have more anticoagulants floating around in your bloodstream when nothing's happening than procoagulants for clotting factors. And when people get an imbalance, then they have a clotting problem and they can die from this, but because of medical intervention, they'll give them more anticoagulants to actually take care of them. And so what are the anticoagulants that we'll give to people to help them if they have too many active procoagulants floating around in their bloodstream? Aspirin. Aspirin is considered an anticoagulant. We're going to talk about that. It's a little different than most of the anticoagulants. Warfarin or Coumadin. Warfarin's the trade name. Coumadin is also kind of a generic name. And what about heparin? Heparin is also a blood thinner. When anybody comes in with obvious clotting problems, they'll give them heparin first before they actually transition them over into Coumadin. Aspirin is an interesting, quote, blood thinner or anticoagulant. It inhibits platelet function. So keeps platelets from sticking and releasing those important chemicals and doing their job. And so whenever you're undergoing a surgical procedure, they'll ask you to, if you are taking aspirin because you're doing it for cardiac reasons, they'll ask you to stop taking aspirin 7 to 10 days before the surgery. Now, does anybody know how many milligrams the aspirin is that most people need to take to? 81. And aspirin, if you take for headaches, is going to be 325 to 500 to 1,000 milligrams a day. So a very small amount has a very large effect. We'll finish our discussion here on the rest of this chapter next time because it's time to go.